The report's terrific, Sarah.
Welcome to the IFA's post-15th Global Conference on Aging thematic discussions among experts, the third of 4 webinars in the series. Today's discussion focuses on the themes of primary and long-term care, specifically the importance of prioritizing prevention to maintain cognitive health in later life. To begin with brief housekeeping, a reminder that this webinar is recorded and streamed live on the IFA Facebook page. This webinar begins with brief remarks from 2 expert speakers, which will be followed by a moderated discussion. Please use the question and answer function along the bottom of your screen to pose any questions or to post your comments for today's speakers. Dr. Barrett, as moderator, will read them out to the speakers during the moderated discussion. Following today's webinar, relevant resources will be posted on the IFA website. And now it is my great pleasure to pass the floor to the Secretary General of the IFA, Dr. Jane Barrett.
And thank you very much, Andra. Good morning, good afternoon, and good evening to everyone. Let me start off by actually just setting some of the scene. While healthy life expectancy is slowly increasing, between 10 to 20% of older people experience some cognitive impairment, and 47 million people live with cognitive impairment severe enough to limit their ability to function in society. While there is considerable variation in cognitive trajectories, cognitive decline becomes increasingly problematic when it impacts the functional ability of older people. But there's also something else that we're going to talk about today. Because in recent years, there has been extensive research examining how age-related hearing loss and brain function, cognition, are associated. There are some general concepts that might contribute to the association between hearing loss and cognition. One theory, for example, is that hearing loss leads to a decreased input to the brain, so that there is less processing that occurs, which contributes to cognitive decline. Another theory is that early cognitive deficits may impact a person's ability to process sound and thus contributing to hearing loss. Irrespective of which theory is correct, it is clear that there's an association between hearing and cognition, and that is very real for many millions of people around the world. This association emphasises the need to not only look at testing and treating hearing loss, but to really look at the preventive mechanisms that each and every one of us have available to us. So it's my great pleasure to introduce these 2 eminent professionals today. First and foremost, the first speaker is Sarah Locke. Sarah Lenz Locke is the Senior Vice President for Policy and Brain Health in AARP's Policy, Research and International Affairs. And it's important to pause there and acknowledge, the tremendous power and work of AARP, not only in the United States, but globally. And the IFA and AARP have such a long, productive and collaborative history in the field of older people and ageing. So Sarah leads AARP's policy initiatives on brain health and care for people living with dementia, including serving as the Executive Director of the Global Council on Brain Health, an independent collaborative of scientists, doctors and policy experts. She also coordinates AARP's role in the Leadership Council of Ageing Organisations, of which I believe there's more than 50 organisations. There's something else I need to tell you about Sarah. She's a member of the American Society on Aging and the National Academy of Social Insurance. Sarah serves on the Dementia-Friendly American National Council and the Health and Aging Policy Fellow Program National Advisory Board member. She formerly served as a commissioner for the American Bar Association's Commission on Law and Aging and on the HHS Administration on Community Living, Aging and Cognitive Health Technical Expert Advisory Board. It's important to frame not only the conversation, but provide background to this important speaker, Ms. Sarah Lenz-Locke. The floor is yours, Sarah.
Thank you, Jane. It's a great pleasure to be here, and I echo your sentiments that IFA and AARP have had a long partnership. It's been very productive, and I hope it continues for quite a while. It's terrific to partner with especially international-facing organization, because the opportunity to share good ideas from abroad is always beneficial. So I'm going to share my screen and start my timer because I am very fortunate to be able to be speaking about a topic that I am very excited about. Can you all see the appropriate screen? I will take that as
Not yet.
Okay.
There's always adventures with the technical aspects of these webinars. So let's just pause until we get this sorted out. And I'm sure Andra and Rashmi are working out what we need to do.
Thank you.
Perfect.
Thank you very much. Even with practice, practice makes perfect. So thank you very much. So we're talking about prioritizing prevention to maintain cognitive health in later life. And it's my pleasure at AARP to lead the policy and brain health team. And at AARP, our mission is to empower people to choose how they will live as they age. And over time, AARP has realized that brain health is fundamental to our mission. And we have focused in three particular areas. Now, today we're talking about prevention, and that's where most of our time and attention will be spent. But I also wanted to say equally important to AARP is the opportunity to help people currently living with dementia and their caregivers. So we also focused on care. And finally, to spark hope for the future, we also are investing in cures, finding multiple ways with multiple shots on goal to try to support innovators in their efforts to come up with a cure for dementia. But one of the reasons that we're talking about prevention is because the science has shown us that we can reduce risk for cognitive decline as we age. So many people think that cognitive aging is inevitable with older age. And what we're here trying to make clear is that it's not inevitable, and there are steps that you can take to make a difference. So about 6 years ago, AARP founded the Global Council on Brain Health. We wanted an independent group of experts to get at the heart of what it is the evidence says currently about what you can do, what works, and what doesn't to maintain your brain health as you age. There's so much conflicting information out there that getting at the current state of the science led AARP in conjunction with Age UK and other long-term liaisons and collaborators to ask experts from all over the world to join us in getting at the heart of what's reliable and what is evidence-based in what you can do to maintain your brain health. And now at almost 28 different countries represented, I think that the International Federation on Aging is the perfect opportunity to share the work of more than 180 brain health experts from around the world. So we are focused on people 50 and older. And at AARP, we are led by what is their driving interests. And so we've done extensive surveys to try to understand what older people they themselves are interested in. And over those 6 years, we have now completed more than 13 reports. This actually doesn't reflect the latest 2 reports we've done on COVID and brain health and now behavior change, which I'm going to be speaking about at extensively in this talk. But the point of this slide is to show you that there are many things that affect your brain health, some more than others. And we now know that modifiable lifestyle factors can reduce risks for up to 40% of the population who has experienced cognitive decline. You're going to hear Carrie speak about hearing, and the Lancet has reported that up to 9% out of that 40% is hearing related. But I guess the good news is that delaying onset of dementia, even if we can't prevent it entirely, could cut the incidence and those numbers that Jane was speaking about that's so scary. We could cut that number in half if we were simply able to delay onset by 5 years. So AARP wanted to find out if people were doing the healthy behaviors and whether or not they understood whether they could impact their brain health. But we started out with the question 5 years ago, is brain health important to you? And over 98% of adults 40 and over said it was very important. But shockingly, only 56% reported that they were doing the most important activities to support brain health. And that was exercise and eating a healthy diet. And those were the people reporting that they did it. The numbers of people who are actually doing it is even smaller. So we know that the brain and its health is important to us, but we must change behavior and adopt healthier habits if we're going to make the impact we want to see. So most recently, the Global Council looked at how to sustain brain healthy behaviors. And our latest report, just published on March 15th, was how to sustain brain healthy behaviors. What are the lessons that we've learned from public health and science that can tell us how to drive the change that we want to see? Again, we reached out to 7 specific behavior change experts from around the world, working very closely with our 13 governance members and 9 liaisons to issue these recommendations. And we encourage you to check out the website and download a copy of this report, because I can only provide the very highlights of the report. But we made recommendations to 3 key audiences. And for each of these 3 key audiences of individuals, communities, and policymakers, the 3 foundational elements that we found are critical to drive change is knowledge, whether or not something works, motivation, and the confidence to implement it. These are the necessary 3 elements for both individuals and their friends and family, for communities, which we define very broadly, communities being employers, nonprofit organizations, the private commercial sector, healthcare providers, aging advocates. One of our listeners may fit into all of those categories, or our listeners may be policymakers, government officials and legislators, interest groups, and business and industry leaders who can really affect the change at a systemic level. And I'm going to be focusing a lot on that. But we know that policies are necessary to support brain health lifestyles. We need both direct policies and indirect policies working together in order to affect the change we want to see. So by coordinating communications, by coordinating and sharing research, those are the direct policies that will support better brain health. Indirect policies, such as the fundamental education and nutrition programs that societies provide, whether or not you have access to healthcare, the social determinants of health are critical in making it easier or more challenging for individuals to implement the brain healthy behaviors that we think are necessary. And the policy tools create the conditions and reshape the environment. So legislation, regulations, consumer incentives, and public information campaigns are absolutely fundamental as we move forward to try to implement the conditions for which it can be possible for people to sustain healthy behaviors. So I talked a little bit about the three foundational elements, but they first have to know what the evidence is. As I mentioned, the Global Council, many other bodies are laying out the evidence so that we know what works and what doesn't. But we have to entice our communities and our policymakers to have the motivation to do something if we're going to make a difference. And the motivation that we've laid out in our report is not only do individuals have the ability to improve their health and well-being as they age, but communities, they themselves can improve the people they serve. We can lower healthcare costs. We can increase tax base. There are so many incentives that should motivate our communities. We need to get those messages out that brain health is fundamental to societal well-being and economic prosperity. And finally, we want to give confidence because we know that there are past successful examples in public health where concerted efforts have made a huge difference in outcomes. Two examples that we cite here and are explained more in the report, seatbelts and anti-smoking laws should give us the great confidence that we have. So we've made recommendations. And the first recommendation is that you have to set a goal, make it a priority with a focus on building equity, because we know that lower income individuals, women, African Americans, Hispanics, are far more likely to suffer from cognitive decline and dementia than other groups. Raising public awareness, tailoring these messages to each of these designated and different audiences are incredibly important. And the social determinants of health shape cognitive well-being. And the last three recommendations are fighting the stigma of dementia. We cannot accept any longer that dementia is an inevitable consequence of aging. It is not a normal part of aging, and we have to resist the fatalism that it is inevitable. Think globally. We're doing it a little bit today by working together across national lines to learn the best practices from every country and actually using the tools to make brain health a top priority. I'm very happy to say the United States has made recent progress in setting a goal in our national plan to address Alzheimer's disease. The Secretary of Health and Human Services has adopted a new national goal on risk reduction and laid out 6 strategic actions that we will be taking and having each of the federal agencies and the community partners that work together in delivering on the national plan. Accelerating research on risk factors is important, but as important is facilitating translation into clinical practice now, because we cannot wait for another generation to suffer cognitive decline because they don't know what to do. AARP has made the Global Council's resources available, and here are a few samples of these reports. They're all available on our website for free to download. The reports themselves are in English and in Spanish, but the infographics, which are one-page summaries of the reports that give takeaway messages to each to individuals who are interested in protecting their brain, are available in English, Spanish, Arabic, Chinese, and French. Several of the other infographics are available in Dutch and several other languages that our experts have been kind enough to help us translate. But we're always looking for partners to distribute these and get them into the hands of people that can use this very practical information. I see that I'm almost out of time, so I want to thank you, and I look forward to Carrie's presentation coming up next, because hearing is so vitally important in protecting and preserving cognitive health as we age.
Thank you very much, Sarah. And before we go on to Dr. Nyman, I really want to applaud AARP for the work that's been undertaken. You know, the resources that you put together, of which we've had the opportunity to look at, you know, are very practical, and they speak to every individual, but also community and the policymakers. And so everyone can win in these strategies towards improving the possibility of cognitive health. So I want every single one of us to actually have a look at those resources. And I ask everybody on the webinar today to use them and push them out. And I know that IFA will be doing exactly that. So thank you for your leadership in all the many places that you are, and for being able to articulate something very complex, you know, in a very simple and bite-sized way. So thank you very much. It's now my great pleasure to introduce Carrie Nyman. Dr. Nyman is an assistant professor in the Division of Otology, Neurotology and Skull-Based Surgery within the Department of, I'm not even going to even try that one, Carrie, otolaryngology.
You're good, no worries.
Not too bad. Head and neck surgery at Johns Hopkins University School of Medicine. Carrie is core faculty at the Johns Hopkins Cochlear Centre for Hearing and Public Health, and principal faculty at the Centre for Innovative Care in Aging. What an interesting combination that you come to us today. Carrie's research incorporates principles and collaborators from across disciplines, which is at the heart of what we believe at IFA can help drive policy, including gerontology, social design, behavioural intervention research, community-based participatory research, and human factors. Your research is focused on understanding and addressing hearing care disparities among older adults through the development and implementation of innovative public health-driven solutions. I know that you just come from clinic, Carrie, and so thank you to come to us from being at the front line of people that need your skills and expertise. So the floor is yours. Thank you.
Thank you so much. I'll go ahead and share my screen as well. So bear with me there. Perfect. Okay, excellent. Well, thank you all for the opportunity to join this conversation. So I know it says here we'll be thinking about advancing hearing health equity for older adults, but I think the two things that I would be excited for everybody to take away from this brief discussion is, one, just to understand where hearing health plays into brain health and healthy aging. We'll touch on that some. And I think the thing that for all of us are so focused on is, you know, what really matters is what can we do about it? So at least share some work that we're doing to try to help move the needle in ensuring access to hearing health for as many older adults as possible is really just a discussion point to get us thinking about what we can actually do to change things. So with that, we'll go ahead, and I just do need to mention I've got two disclosures in terms of, jumped ahead there, let me just go back here. I do have two disclosures in terms of I sit on the nonprofit boards of Access Hears, as well as the Hearing Loss Association of America. Much of what I'll be talking about here in terms of the research side of things has been funded through the National Institutes of Health in the US. So why do we need to be thinking about hearing loss, especially when we're thinking about brain health? Why is that? And some of the things are what a lot of us know already. Many of us know that hearing loss is really common as we get older. Age is really by far the single biggest factor that contributes to our risk of hearing loss as we get older. And that's not too dissimilar to what we see in terms of dementia and cognitive decline, in terms of age being really a big factor. And so while the numbers that I'm sharing here and throughout this presentation are from the United States, these numbers are not really that different across different settings. So when we look in the United States, across everyone who's 70 years or older, 2/3 have a clinically significant hearing loss. When we look at everybody who's 80 years or older, that's greater than 80% have a clinically significant hearing loss. So hearing loss is almost universal. We know that from our daily lives, but it is something that is pretty spectacular in terms of when we're talking about the numbers. So something that has come alongside that really in the past decade is our understanding about hearing loss. We really cannot think about hearing loss as just this benign part of the aging process that really isn't acceptable anymore because of really what we know. Hearing loss has been independently associated with negative outcomes in almost every aspect of aging. So I know a lot of what we're talking about here is around dementia and cognitive decline, but hearing loss has also been associated with things like falls, increased morbidity, increased mortality, in terms of things like depression, social isolation, loneliness, increased hospitalization, and costs. The list really goes on and on. And so one in particular, as Sarah mentioned, is thinking about hearing loss and its connections with dementia and cognitive decline. So there has been a lot of work done just in recent years where we looked at large cohorts of people where we know their hearing status. We also know their cognitive function. And we see pretty much time and time again that there seems to be an association between hearing loss and cognition. We don't know yet the exact pathways, but it is something. When we looked at the Lancet report that came out, this is a big report that came out first in 2017 and then in 2020. And the goal of that report was to think about dementia and all of the potential risk factors that we know goes into that risk of dementia and looking at a population level, so not necessarily at an individual level. And they looked at what are all these things that we know from kind of the best in the literature and best in the evidence. And one of the things that was pretty striking, that for the first time, there was enough literature out there on the potential connection between hearing loss and dementia to actually be included in this report as they did it. And so what we found, or what the Lancet Commission found, was that hearing loss was by far the largest potentially modifiable risk factor when it comes to dementia. And so that's a lot of things to think about in terms of what we mean here again is at a population level. And that is because hearing loss is just so common and the degree of association between hearing loss and dementia is so strong. That's what it came out as the potentially largest modifiable risk factor. And so it's something we need to be thinking about that we haven't always been thinking about when it comes to brain health, is that hearing health is right alongside that. And so that's really raised a lot of questions about, well, do things like using hearing aids actually prevent cognitive decline? Does it prevent dementia? There are a lot of caveats to that in terms of we don't yet know the answer to that. We need large scale studies. Those studies are currently ongoing, one of which is based in the United States at Hopkins and 5 sites throughout the country. We don't know yet the results of that trial. That'll be out in 2023, but it is certainly something that we're thinking about. So with all of that said, as we think about hearing care and access to things like hearing aids, we really are not thinking about it as just access for communication or hearing, which certainly is important, but we're really thinking about hearing care in the context of it is a potentially essential tool for aging well. And how can we ensure that as many older adults have access to these tools as possible? So something that we also know, just while hearing loss is very common, we also really know that there are quite low rates of hearing health care, and that the individuals in terms of the numbers of people who have hearing loss and actually use hearing aids are very small, and that those numbers really haven't changed over the decades now. And that is around just 15 to 20% of individuals, at least in America, who have hearing loss actually use hearing aids. And again, those numbers are not too different across different countries and different resource settings. If nothing else, are even lower in many low resource settings. Something though, when we think about equity, is that yes, low rates of hearing aid use really across the board, but when we think about hearing aid use, we see disparities, differences by things like race, ethnicity, and socioeconomic status or position. So including in the United States, only around 10% of African-American or Mexican-American individuals who have hearing loss actually use hearing aids. And again, if we're thinking about this as a potentially essential tool for aging well, it's really unacceptable. We actually know very little about racial ethnic minority older adults when it comes to hearing loss, because there's just how few individuals have been included and participated in research in the hearing related areas traditionally. So that leaves us with a lot of things that we don't know, some things we do know, and a lot of work to be done. So if we're thinking about hearing health is really this fundamental part of healthy aging and healthy aging in terms of brain health, how can we try to move the needle to encourage and increase access and use of hearing care? This is obviously a multi-component answer in terms of really needing a lot of efforts on a lot of fronts, but I'll share at least one component that we need to be thinking about that we haven't always thought about. And that's in terms of thinking about community delivered hearing care. First, I want to point out that we're at a really special time when it comes to hearing health, and I think a really important time for these types of conversations to be happening. In 2016, the National Academies of Medicine in the United States came up with this one-year kind of committee-long report in terms of understanding hearing health care for older adults. And what they laid out were a number of recommendations. One of those was in terms of thinking about increasing access and affordability. And that was to create over-the-counter hearing aids and allow for that designation so that people can just buy them directly. One of another recommendations that laid out was to encourage community delivered hearing care so that you wouldn't necessarily always have to go to a clinic in order to receive care. That was quickly followed in the United States in 2017 by the passage of legislation that allowed for the official creation of over-the-counter hearing aids, which is something that is expected to roll out in the next year or so, and really is very different from many places in the world in terms of having direct access to high quality over-the-counter devices. In 2021, the WHO released for the first time its World Report on Hearing, something that we're really excited about in terms of laying out the number of different things that need to happen in order to increase access to hearing care, which includes community delivered hearing care. The other thing I'll point out, just as Sarah mentioned in terms of the national plan to address Alzheimer's disease, there was a new action item that is included to increase access to hearing aids with individuals with hearing loss. So there's this unprecedented time in terms of the attention and the priority that's placed on hearing health that really needs to be coming alongside all of our conversations in terms of healthy aging. So community delivered hearing care, what do I mean by that? So what it is things that are what we think of traditionally in terms of hearing care. So it's not based in an audiologist or an ENT clinic generally. It is not delivered just only by audiologists or physicians and using just traditional equipment. We certainly need kind of traditional clinic-based approaches to care for sure, but we need other options to come alongside that. So community delivered hearing care, well, what is it? When I talk about it, I'm talking about it in terms of how do we have access to care in diverse settings where we partner with trained paraprofessionals, individuals who are not necessarily audiologists or physicians, but they may be serving in a supervisory role and using lots of new and different technology. And so that incorporates the idea of task shifting or task sharing, something that has been a long time in the WHO and public health broadly. And that has to do with the rational redistribution of tasks among health workforce teams. And what it's really about is how do we take limited resources and really make sure that they stretch as far as possible so that we're taking tasks from highly qualified trained health workers and shifting them or sharing them with workers who have a shorter training and fewer qualifications. And this is important no matter what setting we're talking about in terms of being able to try and maximize our, in terms of our expertise. We will never have enough audiologists, never enough ENTs in order to reach all of our older adults. Community health workers is a model in which we often are partnering with in terms of task sharing. Community health workers can take many different forms, from promotoras to peer mentors. They're a trusted member of a community, oftentimes have a very close understanding of the community in which they serve, and really is a demonstrated and documented approach to addressing and reducing health disparities. Community health workers have really not been a major partner in terms of delivering hearing care, whether in the United States or elsewhere, especially when we're talking about actually fitting individuals with amplification. There are a couple exciting examples then that's changing that. So community health workers have been working along the US-Mexico border as promotoras and doing a form of oral rehabilitation, which is about basically how to live well with hearing loss. And there's been some great successes there. There's another program called Shruti. It's in part funded by Medtronic. There's a number of community health workers that they have working through both India and Bangladesh and other countries that do door-to-door hearing screening and actually are fitting individuals with hearing aids and whatnot. And then our work in Baltimore is another where we work with older adult peer mentors in a 2-hour session to deliver over-the-counter devices. There's a couple examples of kind of how we go through and talk about hearing loss and the devices. Here are some of our peer mentors in action. And with that, we have seen some really positive and encouraging results and have gone to a larger trial now where we're testing whether or not the program that's designed specifically for older adults delivered entirely outside a clinic setting, in a community setting by older adult peer mentors, less than 2 hours using over-the-counter technology to try to make things as affordable and accessible as possible. And so we have those results are coming. We have had very promising and exciting results that we'll be able to share in a little bit. But I think some of the things that I want to point out about this trial are some of the things that make it different. And really it's community partnership and the fact that we have a very different cohort that has traditionally been included within hearing related research. So around 43% of our cohort identify as African American, and that's really a very large number than traditionally has been included in hearing related trials. And the vast majority identify as low income as well. And so if we are going to ensure that we're reaching all of our older adults, we need to ensure that they're included in our research as well. And so just some reflections from the peer mentors in terms of them on the ground delivering this program. And so I think really speak to the promise and the hope that we have in terms of the power of community delivered hearing care. And so, they speak to, I always tell my clients, you're not alone. So this is an older adult who is teaching another older adult how to use some basic hearing care technology. And they say, I suffer the same problem. I have hearing loss myself. I say, don't be ashamed. There's nothing to be ashamed of. They talk about the importance is because I'm a witness. I myself have a hearing problem and I want you to see me, how a hearing device helps me. And if it can't help you also. That's why it's so important to me, because I don't want nobody to go thinking that you can't be helped. And the last one here, I think they open up to us, they open up a lot more because they can relate to where they are. So what can we do to advance hearing health equity? So I want you to know your hearing status, take action, consider who's not at the table, really thinking about partnerships with communities, collaborating across disciplines, and really embracing technology and moving from there. So with that, I'll go ahead and turn it over.
Thanks very much, Carrie. And if we can have Sarah back on, because I've got some tricky questions for both of you. I think what struck me, Carrie, throughout your presentation, and Sarah also touched on it, those populations that we know are marginalised, we know are isolated, but we don't have good studies on them, right? And if I think about the whole vaccination landscape discussion, they're the very same populations that we find difficult to reach. So what are your thoughts? I mean, you're doing some important work in that very population. So I'd like to hear both of your perspectives as to what's the question? The question is, while we recognise that these marginalised populations are not within research methodologies, how can we actually really push the boundaries to make sure that they are in? And also the age disaggregation also is an important. So it'd be great to hear from both of your perspectives about that. So Carrie, and then back to Sarah.
Yeah, great. No, thank you, Jane. I think some of the principles that we think about both in research and I think can be applied more broadly in terms of, I think the first is the recognition of, do we have the right people at the table for whatever discussion we want to have? And I think really recognizing who's not at the table. Experts can talk to experts, but that is often not reality. It's only one reality. And if we're talking about reaching people who may look different than ourselves, or we may not fully understand, the background, or we think we fully understand the background, it's not enough. So I think having people and inviting people to the table for these types of discussions, I think is huge. I think trust, it can't be reiterated enough in terms of genuinely building trust and maintaining that trust. And if you're going to invite people to the table, you need to listen and you need to take action based on what you're hearing, because we each bring a different expertise. And I think, so I think those are invitation to the table and really being willing to act on what you're hearing, I think are very important, and being committed to the long-term outcomes, so that it's not just something that's happening in a transactional sense of, oh, I need this from you for this one-time thing, but saying, how can we fundamentally work together? And that needs to be a genuine and ongoing process, whether you're talking about research or otherwise.
You know, trust, relationships, listening, and prepared to take action. And I think it's so often we do a lot of listening, we think we do, but then nothing happens. So Sarah, your thoughts?
So I strongly agree with what Carrie was saying, and I want to emphasize that point about being there for the long haul. Like, this is not about going to different groups of people and saying, we want you in our clinical trials. This is about being in community on a consistent basis, having the trusted relationships so that we're listening to those communities and we're hearing what concerns them and we're addressing their concerns. So whether it's things like in the Hispanic community, we know that there are higher rates of cardiovascular disease. What is it about their diet and what is it about their lifestyle that is having such a tremendous difference for their cardiovascular health? Because we know what's good for the heart is good for the brain.
Mm.
So let's look at the fundamental social determinants of health in that community and work with that community by delivering messages that they care about, right? By giving them the information they need and that are actually relevant and pertinent to their life. Because if we're trying to talk to older white women about their brain health, those are not going to be the same conversations that we're having for middle-aged Hispanics in Texas, right? So you have to tailor the messages to the communities and deliver the solutions that work for them.
Look, we've got 3 or 4 questions, so I'm going to zip along. The first question is from Katrina Buzanis. This cross-pollination between, like the word cross-pollination between hearing and brain health seems intuitive in advancing integrated primary care through the decade of healthy aging. What are some of the arguments you could put forward to policymakers to recognise the link? And I will just add, what are some of the arguments you could put forward to civil society for them to recognise the link between hearing and brain health? It does seem intuitive to us. So how are you approaching that in your advocacy? So Sarah, I'll kick it off with you.
So the understanding that there is such a relationship is critically important. It is not part of the regular conversations that healthcare providers are having, as Carrie mentioned, with their clients, right? It's not a kind of conversation that older people are having amongst themselves. Oh, they know about hearing and they're talking about hearing loss, but they have not yet really made the connection between hearing well-being and cognitive well-being over the trajectory of their health. So beginning to change those conversations to make it part of everyday life is the first step. And then to show that we can improve well-being, that we can make a difference in function.
Yes.
If people can hear, that we can improve the economics for people because we're helping their quality of life. To me, those are some of the fundamental arguments that need to be brought to policymakers to understand the real difference this can make.
There's a real business case, isn't there? We don't want to say it, but there is a business case. So, Carrie, I want you to just quickly comment on that, and then I'm going to come back about cost. So did you want to make a brief comment?
Yeah, I agree with everything that Sarah said. And I think that the biggest thing is that it's actionable, and that it is something that does not necessarily require thousands of dollars in terms of hearing aids. Yes, that may be what it costs in some places, but that is changing. And the more that we think about and embrace over-the-counter devices and over-the-counter technology and get comfortable with that, I think the better, because those are the types of pressures that we need in order to make more accessible technology. And yes, it's not all about technology, but that is one component. And just to know that it is changing and that there's options out there even now.
And of course, we do have the WHO app, to test hearing, which I need to do this weekend. So, Andra, can you put that link to the app in the chat box? Question from Erica Dar, great friend and colleague from AARP. The cost of assistive devices, such as hearing aids, prescription glasses, are not covered by Medicaid and Medicare. And guess what? It's not covered by Medibank in Australia either, and OHIP here. What is being done to address cost compensation as we deal with ageing populations like me? So Carrie, give that a go, and I'll come back to you, Sarah.
It's a great question. I want to make one point first in terms of when we look to places where hearing aids are covered, like the NHS in the UK, rates of hearing aid use are higher, but they are not there. It is not the end all be all. So I want to at least just point out that yes, we do need policies that address cost, but I think the realization that services and how do we break down those barriers to services as much as possible is another important part of the conversation, that we can't just look to say, hey, insurance coverage will just make this problem all go away. So that's one. And then I think for us, in the United States, as we are trying to encourage an over-the-counter, a robust market around over-the-counter devices, I think thinking about how do we encourage that market, but at the same time ensure access to services, and really value our audiologist colleagues' contribution to be able to bill and have coverage for communication. Education is a big part of it that needs to happen as well. So for sure.
But of course, this whole webinar is being about preventive mechanisms, isn't it? So it's about understanding or being aware enough, to actually, there are 6 actions that I can take around my cognitive health. There are actions I can take around my hearing health. I'm wondering to what degree organisations like IFA or AARP or Help Age or even Rotary and Seroptimist should start actually having this conversation, because it goes well beyond, it's not an aging issue. It's really a life course approach to cognitive health and hearing health. So I just leave that with you, and I'm going to go back to another question. Could speakers comment on experience of cross-training and providing education to care workers? For example, how are such initiatives received, and what are some of the barriers? So what we're really saying is there's not enough, and there will never be enough, clinicians in various areas. So as care workers are being asked to be vaccinators, so is there any problem, tension that you can see around cross-training? Carrie, and then I'll go to Sarah.
Yeah, no, it's a great question. I just like we think about all of the frontline providers and how much we ask of them. My hope would be, just as we think about for everybody, that hearing health to just at least cross your radar. I think it's one more, to me, I think, thing that needs to be added. Just if we are going to have a comprehensive approach and really have a holistic approach to the older adult, who's in front of us, yes, we need to be thinking about their vaccine status, but we also need to make sure that they can understand us and engage with us. So it's so fundamental when we're talking about senses and cognition, that while I think, yes, there is some tension in terms of just how much we're asking for individuals, but I do think it is a really tangible way that people can make a difference in terms of saying, hey, this is one thing on your list that let's talk about this, and potentially we can address it in a fairly, pragmatic, straightforward way. We're not necessarily talking about, months of working on weight loss or changing diet, but we're talking about, hey, let's see what your hearing is. Let's think about getting a device, getting you comfortable with a device, and let's get something off your list of all the things that you need to be thinking about.
Off my list, it will be done. Sarah, I want to go to you and talk about brain health in the midst of a pandemic, because we are still, the world is still in the middle of a pandemic. Let's not sugarcoat it. To what degree, has the pandemic impacted research, in brain health? And also, what can you see that there, I know people talk about the opportunities of pandemics, but believe me, I'm not sure that there are many. So comment on, research monies, and also to what degree has the agenda to drive brain health been impacted by the pandemic? Because certainly, the policy issues and investments have certainly gone sideways. So your thoughts, I'll come to Carrie and then we'll start wrapping up.
So the pandemic has not stopped the investment into research. Fortunately, that has been underway and ongoing, but it's diverted some of them because we found a tremendous impact of COVID on brain health, frankly. Long-term COVID is a huge issue. ARP's and Global Council on Brain Health issued 2 reports on the relationship of COVID to brain health. Early on, we talked about that it's not just a disease of the lungs, but that it is affecting the brain. Actually, probably Carrie can speak to how it's actually have been linked to some hearing issues. But the funding has now had to go to also investigate how COVID impacts the long-term aspects of brain health. But the opportunity that the pandemic has provided is, unfortunately, it has showed us in spades the long-term consequences of social isolation and the huge impact that the negative impact on mental well-being has had on older adults. We know that people living with dementia have died in far higher numbers than others as a result of COVID, and the frailest elderly have suffered the greatest. So we've learned a lot, unfortunately, from COVID, and it's highlighted the terrible problems that we have in our long-term care systems, and actually created some incentives to fix this terrible problem that we in aging have known for a long time, but has been isolated and highlighted.
Yes.
COVID.
Yes.
So through the tragedy, it is a hope that reform will finally happen at the scale and the speed it needs to. We're finding the problems with inadequate staffing and care for people living in long-term care facilities is only getting worse. And the hope is that we can use the lessons of COVID, the impacts of social isolation and mental distress in ways that we can build on for the future.
So I guess the takeaway message for me is that we can't take our foot off the pedal yet. We've got to keep moving forward. So Carrie, your comment?
I think the opportunity, like you said, if you can say that, I think has really pushed us to think differently about care delivery models in terms of how do we reach people, with virtual and incorporating different technologies that we may not have always thought about as heavily, because I think that can often translate to more cost-effective approaches as well, and farther reach that we may not have always had. I think the other side of it, in terms of just having more conversations, I think there's many more conversations that are being had around social determinants of health, around equity, that I think, certainly need to continue as well.
Look, stay there, because we're just going to now just mention our next and final webinar in this series in collaboration and partnership with AARP. So if I can have the slide up. So we will be talking about ageism, addressing structural ageism to unlock a longevity economy. It's good that I'm moderating that, because I'm sure I need to learn a lot. So we're going to have experts from AARP, Dr. Irwin Tan and Mr. Peter Rundlett, and our colleague from ILC, International Longevity Centre, United Kingdom, Miss Lily Parsi. So join with us 3rd of May from 12 p.m. to 1 p.m. next week. So thank you. I'm now going to thank both of our expert speakers. Look, what a fascinating area. But I want to come back to some key words. Listen, trust, action, modifiable factors, inequity, marginalised population, pandemic, social isolation. All of these pepper all of the conversations. I think really at the forefront is we have an individual, a community and a societal responsibility to drive policy, influencing and shaping across sectors and across disciplines. So they're my takeaway messages. So I'm going to ask Sarah and then Carrie, what's your takeaway message to the audience at this webinar, and also that we'll be seeing this around the world this afternoon?
The vast potential of us to make a difference in people's brain health across their lifespan is enormous. Taking steps, starting simple, setting a goal, and moving towards it is going to make a tremendous difference for individuals and communities and society. And we need to start today.
Look, thank you very much. And we will start today. Just want to acknowledge the work of AARP and the Global Council, the resources. We will have them in our voltage and we will be pushing them out. And I think Sarah and Carrie and I, we need to talk about the theme for the conference next year, what it's going to be. So your final word, Carrie.
So I think, like Sarah, I think just a reminder that that hearing loss is something that almost all of us will experience, and we know that, but that we can't necessarily take that for granted and say, there's nothing to do about it. There are things that we can do, and the opportunity and the time is right now for us to think about new ways of doing things that are affordable, that are accessible, to really make progress and not have the senses and hearing health be left us behind as we're thinking about healthy aging and the decade of healthy aging, that it needs to be right alongside all of these conversations.
All right. And with you too, being part of the leadership team globally, we'll follow behind you or stand beside you. So thank you very much for your time today and your expertise. I'd also like to thank the IFA team, and in particular, Rashmi Gupta and Andra Stanku. So thank you very much. And also to AARP, thank you for being our partner. All the best. Bye-bye.
Best. Bye-bye.